All right, well, we're down to our last presenter, and it's my pleasure to introduce Dr. Mark Gilbert, who's going to be presenting, doing a presentation on sustaining an effective response to acute HIV infection among gay men. So, Mark, can I ask you to come up while I present? Give your bio. So Dr. Mark Gilbert is a community medicine specialist at Clinical Prevention Services at the BC Centre for Disease Control, which is where he leads the epidemiology and surveillance and online sexual health services programs. In addition to initiatives to enhance current surveillance, his areas of interest include testing for HIV and other STIs, internet-based approaches to sexual health promotion, and gay men's sexual health.
Great. Thanks, Mike. Okay, well, thanks, everyone. And I'll do my best to move through this fairly quickly. And certainly, I just want to acknowledge that certainly the contribution of Mike, Malcolm, Daryl, and Mel to my presentation today, but also just to acknowledge that I'm one of the co-PIs on the study, and that's a relatively new role for me with the study. And certainly, I'm speaking on behalf of a large number of people, including many people in the room here who've been part of our study, and certainly want to acknowledge their contribution. So what I want to touch base on today is just some basic background around acute HIV and window periods, talk a bit about the CHR study and the associated social marketing campaigns, and then really to focus a bit on the description of the impact of introducing testing for acute HIV infection, which is pooled NAAT testing, and to then talk briefly about what our current policy options are and next steps in terms of sustaining the availability of this technology. So I just want to do a quick show of hands. Who here feels they understand the concept of a window period for HIV testing? Okay, good. So that's pretty clear. How about, do people understand the term acute HIV infection and what I mean by that? Great. How about pooled NAAT testing? Awesome. Okay, great. So I'll work through the background very quickly then, and we can move on then to some of the discussion. But just briefly then, so for acute HIV infection, it's this period in the first 6 to 8 weeks when viral loads are very high and there's a higher probability of transmission to others. And that's one of the main reasons from a public health perspective that we're concerned with diagnosing acute infection. And obviously we know the diagnosis of HIV, regardless of when it happens, leads to behavior change. So the earlier the better. And we also know that acute infection, because it indicates very recent infection, likely means that these are men who are in highly active sexual networks. And so there may be an opportunity through things like partner notification to reach partners in these very active networks. So HIV tests are based on essentially sort of three main components. The viral RNA, sort of that's what you would measure if you're doing a viral load, and that appears first after infection, followed by the P24 antigen, which is a protein component of the virus, which sort of peaks at about 2 to 4 weeks and then goes away. And then you have the antibody response. And it's really the RNA and the antibody that sort of are present over the long term. And so different tests test for different things, and so that's partly why different tests have different window periods. So just in terms of the standard testing protocol, so if you went into any clinic in BC and you had a blood draw that was sent to sort of the provincial public lab, which does the majority of HIV testing in the province, this is the algorithm that happens. So the first test is the third generation EIA test, and that's a screening test, the first screening test. And that's an antibody test, and it means that the window period is about 3 to 4 weeks. Sort of the mean window period is about 3 or 4 weeks for that test. A fourth generation EIA test, which also tests for the antigen, the protein P24 antigen, is used to help if there's a reactive or some kind of signal on third generation. And then the Western blot is sort of our ultimate confirmatory test for HIV. And then if you can see that there's a period where, the Western blot may not be fully reactive, and then we would do an individual NAAT, so looking for the virus on an individual specimen, and that helps to resolve the differences. So the two key points are that the window period is 3 to 4 weeks, the mean window period, and that even under the standard testing protocol, we can identify people who have acute HIV infection, which is sort of the first 6 to 8 weeks, and so we can under that standard protocol. With pooled NAAT testing, so what this is, that's the same technology used by the Canadian Blood Services to screen blood donations. And essentially what happens, the specimens at the lab go through the same process. If it's a reactive on the third generation screen, it goes through the same series of tests. But if it's negative, the specimen then gets added to a pool, and the whole pool is tested using pooled RNA NAAT. So if a pool is positive, it means there's virus in the pool, and it gets broken down into individual specimens to find the specimen that has the presence of the virus. And the real advantage here is that it shrinks the window period to 10 to 12 days. So this clearly is a very smart room, so this slide might not apply. But window periods and HIV, acute HIV, is quite difficult. And if you put yourself in the position of like the average gay guy, it may be difficult concepts to try to understand. So certainly, window periods, what are all these different kinds of tests mean, like the acute infection test, early test, rapid test, and then also why is acute HIV important? And there are definite ramifications to this, like knowledge gap. We know that there are still gay guys as well as providers who think that they need to wait 3 to 6 months to get an HIV test, and also, guys not taking advantage of current tests. So as part of the study, we've been working closely with him in terms of in supporting some social marketing campaigns. This was the first social marketing campaign, the What Are You Waiting For campaign, where the emphasis was really on trying to provide information describing the different kinds of tests, standard, rapid, early test, as well as the merits to both and when it might be appropriate one versus the other. And then most recently, the Hottest at the Start campaign, which was focused more exclusively on acute HIV infection and the early test, and really trying to convey the knowledge that about the importance of acute HIV infection, and there's a test available early on in infection to tell you if you have HIV. So that's kind of the background. So let me just tell you briefly about our study. So there's many objectives in our study. It's quite a large study. But the two that are most relevant to the discussion today are the first, which was really, and this is probably the main objective of the study, is to diagnose acutely infected gay, bisexual, and other men who have sex with men using new laboratory testing methods. In this case, we're talking about the pooled NAAT test. And then second, to promote HIV testing as a first response to risk events or potential exposures through social marketing. And that's sort of the rationale for the social marketing campaigns. Briefly, the methods. It's a mixed method study, so it combines qualitative and quantitative or survey components. And men who are diagnosed with HIV are recruited into a longitudinal cohort, and so they're followed over time. The recruitment is going until the end of next year, December 2012. Eligibility are men who identify as gay or other men who have sex with men and are 19 years of age or older and have a diagnosis of either acute HIV or recent HIV. And recent means that they've had a previous negative test in the last 12 months. Now, the study sites, the pooled NAAT test is available at 7 clinics in Vancouver, and these are clinics that were selected on the basis of our understanding that these are clinics where there are a lot of gay men who go for service. As well as we've looked at some of the historical testing patterns, and we know that these are also clinics where traditionally in the past, a number of gay men have been diagnosed with HIV, and so that was sort of the basis for selecting these 7 study sites. And the intervention was at these sites, the implementation of the NAAT testing protocol, the pooled NAAT testing, as well as enhanced support through professional and peer-based counseling for people with a diagnosis of HIV. Currently, we have 23 men in the cohort, 9 acute and 14 that are recent, and that certainly seems like a low number, and I think we were hoping for more, but this is actually quite comparable, if not better, to other cohorts that have been really trying to recruit men with acute HIV infection, because as you can imagine, it's a difficult time to be talking to people about participation in research studies. So for this analysis, what I'm going to present today is that we're just looking at the laboratory testing data from the Provincial Public Health Laboratory at PHSA to describe the impact of introducing pooled NAAT testing at our study sites. And this is really doing a comparison of the pre and post test, or pre and post pooling periods. So this graph, we'll spend a bit of time on it, essentially visually tells you what we found. So this graph shows by quarter, so every 3 months, the number of new HIV diagnoses at the 7 study sites. So the height of the bar represents the number of new diagnoses in that quarter. And so the purple at the bottom are the number of acute HIV infections. Gray is recent, so men with a previous negative test in the past year. And then green are other men who either have established infection or they may be recent, but we haven't been able to identify them as recent. So the key thing here is to look at the period before and after the implementation of pooled NAAT, which is shown by sort of the horizontal purple arrow. And certainly I think even visually you can get an appreciation that after the impact of pooled NAAT, we do see an increase in the number of acute HIV infections that are detected at the study sites. And just to point out, the blue arrows at the top reflect the timing of the social marketing campaigns related to this, because that will likely have an impact on these statistics as well. To show this more numerically, this is comparing again sort of the pre and post implementation periods for pooled NAAT. And what we see is that overall there's an increase during these periods in terms of the number of specimens sent for testing as well as number of individual people testing. We've also seen, and then if you look at the bits in red, Overall, the number of new diagnoses decreased a little bit over these two time periods, but the number of acute HIV cases more than doubled as a result of the introduction of the pooled NAAT testing, and a slight increase in the number of recent HIV cases. Now, what we did is we went back and we looked at if pooled NAAT testing had not been available at these study sites. We determined that 14 of the 34 acute infections would have been missed by not having pooled NAAT testing if we had just relied on the standard HIV testing algorithm. So there's many factors, probably several factors that could be explaining the increase. The most obvious or essential one is the introduction of the pooled NAAT testing, because that allows for the detection of acute HIV infection. Likely impact of social marketing campaigns about men becoming aware of the availability of the testing and coming in for the testing. And then other factors that might explain sort of increased testing volume. There's probably other things that we haven't really thought about, but some of the other components of the study will allow us to examine this in a little bit more detail and maybe get some of the context behind this. So our conclusion, and what we found by introducing pooled NAAT, is that it is definitely effective. So we've made diagnoses of HIV infection that would otherwise be missed, and this means, we think, greater opportunities for prevention of HIV transmission, and we sort of really feel that pooled NAAT testing, or testing for acute infection, is a valuable prevention tool for gay men. So the question now becomes, what do we do now? So the study ends in a year, and what are our plans related to that? So there is a bit of a buzz around acute HIV at the moment. I will say, certainly from the outset, the potential benefit of the acute HIV test and pooled NAAT has really been recognized by our community partners as well as public health partners, who really see how this can be well integrated within sort of the options for HIV testing for gay men. And certainly now that we've been sharing some of these preliminary findings, it sort of is reinforcing that support for the methodology. And we have also now been talking about the results of this study within the various levels of the Stop HIV program. So we've talked about the results of this with even up to sort of, it's gone up to the Associate Deputy Minister, for example. And there has been a lot of excitement about, or interest anyway, in terms of the impact of introducing pooled NAAT. So this is a bit of an opportunity for us to be trying to push options around sustainability. Now, there are two main options that we can consider. The first is at least sustaining pooled NAAT at the 7 study sites, or expanding pooled NAAT to other sites in the Lower Mainland across the province. The problem, one of the problems with pooled NAAT is just that it's a very expensive test. So it's not something that would be cost effective to do routinely for all specimens that are coming into the provincial public health laboratory. So we're looking at so the options being sustaining at least at the study sites where it's currently implemented, but also expanding to other selected testing sites where we might expect where we may have a similar kind of impact, with some consideration of what might be appropriate regional representation around the province or regional access around the province. So that's one option. And then the second option is, and this is something that's also under consideration, is instead of using a 3rd-generation screening test, using a 4th-generation screening test. And increasingly, I think over time, most labs are going to be moving towards a 4th-generation screening test. So as you recall, it includes the test for the P24 antigen, and so it does decrease the window period, but not to the same degree that pooled NAAT will decrease the window period. So with this option, this is the route that Quebec has taken. For a couple of years now, they've been using 4th-generation tests as their initial screening test. It is definitely a cheaper test, and it is something that's possible to implement across the province routinely for all specimens coming into the laboratory. And in fact, I think in VHUD in Victoria does their own testing, and they're currently using 4th-generation tests. And it certainly, we do know that it does reduce the window period, and it would detect more acute HIV infections than using the current 3rd-generation test as the screening test. However, we do know that this would miss many acute HIV infections as well. So we went back and we looked. If you recall, I said that there were 14 men who would not have been picked up using the standard test. Well, if we had used the 4th generation, we would have still missed 40 to 70%. So a number of those acute infections would have been missed. And this is particularly important for gay men because certainly in the literature and some of our experience in BC has been that gay men in particular are more likely to test during the acute phase of infection. So our acute infections in BC are more likely to be gay men and other men who have sex with men compared to other groups. So where are we at? Where are we at now? What next? Well, we feel that there are definitely merits to both options, and our preference is both, because I think there's a value across the province to reducing the window period, but I think that there's still substantial benefit to be had from pooled NAAT testing, although it's not going to be realistic to be doing it on a provincial basis. So at the moment, we are preparing our sort of appropriate policy documents and business cases so we can actually present these options for consideration, and doing some exploration of if we were to expand pooled NAAT testing in a targeted format, what would that look like and at what sites across the province. We're also, next year as a result of the study, or as part of the study, going to be doing some further head-to-head comparisons of pooled NAAT testing and fourth generation screening tests, which will allow us to have a little bit more information about the merits and pros and cons to both tests. And right now, we're also thinking quite actively, and that's partly why we're presenting it here today. So presenting these findings so people are aware of this and sort of contributing to knowledge translation about the issue. There. So I will end there. I guess it's good that I talked.
Yeah. Great. So could I actually ask the presenters to come up just for the last 10 minutes of this panel, just to facilitate the question and answer session. So if anyone has any questions for any of the three presenters, please just head on over to the mics. Go ahead, Riaz.
Riaz from Montreal. The question is for Mark. Do we really know that pooled NAAT is not going to be cost effective?
Sorry. Yeah, no, it's on it. Yeah, it is something we have to look at that a little bit more formally and fully. But certainly that seems to be what we're finding from other places which have done this as well. So we're the only site in Canada which has implemented pooled NAAT, but there are definitely other sites in the U.S. that have done this, and that's been their conclusion as well when they've done more rigorous cost-effectiveness analysis. So it's something that we haven't done fully in detail for BC, but it is something that we found from other places that have done it.
Can I ask something more? What you were saying about the introduction of like the fourth generation ELISA in Quebec, we're still seeing about 40% of gay men testing that are being diagnosed every year in Quebec at like almost AIDS stage. So with all of this, and I do understand like the importance of this, and I think when this project started, I was very jealous. I was following it from Montreal. Is that the message that's missing is this 3 months window period that we keep on telling people that they need to wait before getting tested. And I really like what you said about the first response should be go get a test for everything today.
Yeah.
And I really think we really need to move away from that because there's no point in waiting.
Yeah, we would totally agree, and that's part of our learning as going through this process as well, is thinking through what is the messaging that we give, not just to gay men about when to get a test, but also to providers about like the appropriate when to get tested. One of the challenges is that people want certainty, so they want to know if I get tested at this time and my result is negative, I'm good. And there's certainly when you get closer to the time of infection, we don't really have that kind of certainty because it's very difficult to know, obviously, when a test will become positive. So it does require some more training and knowledge on the behalf, particularly of providers who are explaining tests about what they mean and when. You can be confident. I mean, we've recently had some discussion about, so what we currently say in BC is that with the standard testing protocol, by about 4 to 6 weeks, you have probably about a 90-95% chance. If it's negative, it's negative. But at 3 months, it's almost everyone. If you're negative, you're negative. And I think that's helpful to have that kind of messaging. We're looking at how that changes with pooled NAAT, where it's probably no longer waiting 3 months to where you can probably rule it out sooner. So we're looking at those kind of messaging to make sure that people have the most accurate and up-to-date information.
Thanks, Riaz. Malcolm, you have a question?
Malcolm Steinberg, SFU and BCCDC. Just perhaps, if I may add a comment to the previous question about cost effectiveness, the studies that we've looked at in the US have concluded that they are in fact cost effective in particular settings. And interestingly, the settings that they were shown to be cost effective were community-based settings that provide testing mainly for gay men and MSM. This is a question to James and perhaps Travis and Janine as well. James, you spoke about community-based involvement in HIV testing, and what I heard you mainly referring to was looking at this through a lens of whether community-based testing could provide adequate access from using a technology lens. And I just want to ask you whether you reflected on engaging communities in actually the structuring and the development of programming per se, in terms of being able to access marginalized populations. And that would apply similarly to the internet survey. And an extension to that is, given the wide use of internet and online modalities, would there be any way in which people could access an internet service and then, in a way, import that into their own internet and online media, and in that way disseminate information and messages?
Okay, so regarding engaging the community in the design of the structuring of how HIV testing would be implemented within their communities, that's the question. I couldn't not. I think one of the strongest points that came out that I didn't really emphasize in my talk was within many community-based organizations, there's a high degree of, or moderate degree of distrust of public health institutions. And so they felt that there was possibly a better way than we've managed to come up with over time that they could conceive of and implement in terms of how to design access and how to implement a program that made HIV testing available to their community members. Certainly they had the sense, by and large, that from their perspective at the community level, they had a clearer view of the deficits and what needed to be done in order to address those deficits. So I didn't ask that question. I didn't ask what they thought it might look like, but certainly the feedback from the participants of the focus groups was loud and clear that it was absolutely critical to consider that. As a matter of fact, to the point that I said earlier, that that's possibly where we haven't done things quite so well from within public health.
Well, I think that we've been thinking along those lines in terms of getting community feedback on the development of Get Checked specifically. So we've been doing focus groups. So for the pilot phase, we've been doing focus groups with our target populations. And I think one of the major recommendations in a direction that we're already moving in is kind of going beyond those initial sort of priority groups to get their opinions on Get Checked and how it works for them and how they think it will work as we plan and think about scaling up. So we've already started planning that kind of focus group, and I think that it will be essential to our sort of thinking and planning how we can go beyond a model that works within kind of the urban Vancouver setting to get input from people that are not from Vancouver to sort of help us strategize how we can make the program work. And that comes with building, I think, community partnerships and kind of hopefully, if we can possibly do focus group work or other kinds of that qualitative work outside of the populations that we've already done outside of Vancouver.
I would just add that, so apart from Get Checked, we're also revamping our sexual health website. Early next year, we'll launch a new sexual health website for BC called Smart Sex BC. And one of the nice things about the evolving technology of the internet is that there are things like widgets, which we will have on Smart Sex BC nurses who are available to answer questions about sexual health online, and there will be a widget for that function that our community-based partners can install on their websites as well. So I don't know if that gets at your point a bit, Malcolm, about how we'll partner with other community organizations. We haven't talked about similar technology for Get Checked, but we definitely believe, just like James said, that we can't really build and expand the program without partnership with community-based organizations. We see our role as sort of developing and evaluating the technology, but in terms of bringing that to particular communities, that's really the area of strength of our community partners. So.
Any more questions for any of our presenters? All right. Well, I guess that means we can break a little bit early for lunch. So I've been advised to just let you guys know that we have lunch until 1 o'clock only. So thanks again for joining us for this panel, and hope you enjoy the rest of the summit. Yeah, thank you.